Welcome to the Peds Hub podcast. We are a group of paediatric trainees in the Southwest who every month review a selection of articles that we find useful for our practice.
These are taken from the BMJ Archives of Disease in Childhood journals.
For the full articles, please go to their website, journals.bmj.com. Please note, these are our own opinions and are produced for educational purposes only. They are not intended to substitute professional medical advice, diagnosis, or treatment.
Thanks for listening.
Hello, welcome to the Peds Hub podcast. My name is Felicity Cooksey and I'm a paediatric trainee in the Severn Deanery. Today I'm very pleased to welcome back Dr. Sarah Bridges, a paediatric consultant working in Musgrove Park Hospital. We're going to be talking about help-seeking behaviours and giving safety netting advice today. So thank you for joining me.
I know, it's a pleasure. I like doing the last one and I like the fact it's just a conversation rather than having to do a presentation or anything. It made it much easier for me.
Wonderful. How are you today?
I'm good, thank you. We've just finished Friday making little crafty dinosaurs, so that's good.
It's absolutely fantastic. For our new listeners, could you tell us a little bit about yourselves?
Yep, so I'm a general paediatrician working at Musgrove Park and I've been a consultant here for just over 20 years. Rapidly learnt in my consultant career that safety netting is possibly the most important part of our work. We have a lot of children presenting acutely, and we know that acute illness presents in really non-specific ways to start with, and that we can't admit absolutely everybody with a non-specific sign. So learning how to safety net effectively really early on in my career became an important thing, and obviously it's changed over the years how we do that, and now we're actively learning and training other people how to do it.
Yeah, I thought this was really interesting because we're not often taught specifically how to safety net. I think it often happens almost by osmosis.
I think that's right. I think when you're an SHO, you're learning how to spot the sick child, aren't you? As a registrar, you learn how to manage that child for the first few hours or the first day until the next ward round. And then suddenly you hit being a consultant and you're having to make the decisions about who can go home and who can't. But you can only do that safely if you can be reassured they'll come back if things change.
Yeah. So the article we're discussing was published in the last month's Archives of Disease in Childhood. It's titled Parental and Physician Disagreement on Help Seeking in Paediatric Case Scenarios, and it's by Sarah Vischer and her colleagues. So this study was aiming to find out what symptoms cause a parent or caregiver to seek medical advice for a child. As paediatricians, we have a set of serious signs or symptoms, so our red flags, where we would want a child to be getting a medical review, and this study was asking the question, what symptoms lead a parent to seek medical advice? And how does that compare with when a physician would wish parents to seek help? The study took place in the Netherlands, where, similar to the UK, seeing a GP is free and it's intended to be the first port of call for worried parents. The authors set up a survey where they gave 200 parents theoretical scenarios, and at different stages of the scenarios, they asked if the parents would be seeking medical attention. They collected baseline demographic information at the start, and then they went through the same scenarios with 54 GPs and asked if they would wish parents to be contacting them. So then if we take a little look at the results.
I've got the graphs in front of me. I mean, what they've done is they've looked at various conditions, haven't they? Appendicitis, otitis, brain tumour and septic arthritis type cases. What's interesting to me and what's apparent just from the patients we have on our ward is that your decision to seek help isn't just based on your child's symptoms. It's based on what your own health experiences as well, what you've experienced previously, what other people have told you, whether you've got a telephone, whether you've got transport. Because if you haven't got a car and someone's going by going, actually, I can give you a lift up to the hospital now, even with the less severe symptoms, you're going to go and seek advice at that point.
Yeah, and it's interesting with this, they were saying that if you were a first-time parent, you were more likely to seek help.
And I think there's been lots of evidence about that, about how our families are much more geographically spread nowadays, that you haven't got a grandparent who can go, oh yeah, you're vomiting, have some Diarrhea, here you go. You've lost that sort of grandparental sort of extended family input, that actually you're a much smaller unit. You're a mum, a dad and a child, and you're trying to make those best decisions. It's been even worse during COVID, of course, and we've seen, the mums and dads have watched all these people get really unwell on ventilators numbers on the TV, a number of people dying, but as soon as their child gets unwell and is short of breath, it changes your sickness behaviour. So I think a lot of this also depends on your own sickness experience and what you've had yourself.
So this is a small study, and it's obviously set in the Netherlands, but I thought it was interesting how parents seem to respond to fever as a symptom. So that seemed to be a trigger to seek help, which was different compared to the physicians.
Yeah, I think people are really scared of fever, aren't they? They're scared of what it means. There's much more awareness of sepsis and meningitis, that fever is something that a lot of people are worried about. A lot of GPs are worried about as well, to be honest. And as we know from our NICE guidance, people try and sort of segregate risk factors into amber, red, green. But actually, for us as clinicians, it's much more holistic than that. It's the whole picture of the child, and it's really hard to give hard and fast reassuring or advice about fever guidelines. And really, it's understanding what they're concerned about. What is their fear about the fever? What is it that's making them feel their child needs an assessment? And this is the case with a lot of our cases in paediatrics, is understanding why the family are concerned and what they're concerned about. Because if you don't get that, none of your advice or treatment will mean anything. So I often really make an effort to understand that. But obviously in our early warning system guidelines, gut feel from the parent or anxiety from a parent actually scores highly because they know their children well. And if they are disproportionately concerned more than you have to really question yourself as to why are you reassured? What is it about this child that makes you feel this child is okay?
Yeah, parents didn't seem to have the same awareness of some of the other red flags. In this case, there were statistically significant differences between physicians and parents in the upper respiratory tract infection case and the case of a brain tumour, where in terms of level of parental concern and physicians really differed. Headache with early morning vomiting and drowsiness would have, at that point when you had all three of those, 92% of physicians said, they would definitely want that child to be having medical evaluation. And actually only half of parents with those symptoms had suggested that they would be contacting their GP.
Yeah, and I think that's because as adults you're used to having headaches more often, but we know it's a relatively rarer thing in children. So their own experience is, they've got a headache, it's fine. But as you say, the important red flag is the waking up at night or in the morning with the headache that make us worried. I mean, we can see that the physicians are extremely worried, even just with drowsiness or diplopia or painful neck flexion or ataxia. I mean, you wonder what a parent would understand by ataxia anyway, or would they understand what that meant if their child was
off balance?
Yeah, exactly. You'd just think that it's part of them feeling unwell and not right, rather than necessarily being a neurological sign.
Yeah.
It's almost like safety netting prior to having any illness.
Yeah.
Which is different from the safety netting we provide in hospital when they go home, when you can hone it much more to how they've presented. You've got an awareness of who they are, what they're scared of and what their challenges are. So providing safety netting advice to children and families who've previously been completely well, I think it's hard, because then you're not engaged as much, are you, in that child or in those symptoms.
In terms of your approach to safety netting, how do you tend to approach it generically?
Yeah, so over the years, I say it's changed how we've done it, and there's the two main aspects. There's the prior to your child getting unwell, and as you know, we've got the handy app, and we've got an algorithm there for red, amber, green symptoms and when you should go and seek medical help. But there's a difficulty with reading written advice when you're stressed. Or first of all, where you're going to find the advice. Do you buy into it or do you believe it? Do you read it appropriately as the clinician has written it? So I find the safety netting prior to someone getting unwell, so advice on when to seek help, quite tricky. Once you've seen a child or a child is presented with a certain condition, as a clinician, that naturally points you down a certain pathway. By the time you've met a patient, you are using all your skills to sort of understand what they're scared of, what their sort of sickness behaviours are, and you've got an understanding of their sort of social setting. Have they got transport? Have they got a phone? Or what is their understanding of the written information? So you are able to give much more specific safety netting advice. Of course, you can't just say these are the times that I'd be worried. You need to tell them what to do for each of those occasions. Otherwise, you just stress them out. Say you had a croup patient that came into the ward and you were sending them home and you want them to come back if it gets worse. We wouldn't say, if it gets worse, let us know, because there's a chance that your airway could close over. I mean, that's an extreme example, I know. But what you want to say is, okay, if you've got stridor at rest and it's not settling, we need you to phone this number and arrange to come back so that we can see you. There's got to be a what if. So if you have that, then you do this. Because for some things, for less urgent things like D and V or something, if your diarrhea goes on for more than 6 weeks, or if you've lost weight, you might want to go and see your GP so they can do an assessment. But you've got to do if this happens, this is what you need to do. Even our discharge summaries, so our discharge summaries from the ward are really safety nets. They are describing, child's been in the ward with this, we now think they're okay, but we very often miss out the next bit. If this happens, this is what you need to do. We're using it as a handover from one clinician to another, from the acute wards to the GPs. But actually the families have got a copy of this as well, and the GPs want to know what the safety netting is, so we should be putting safety netting things into our discharge letters as well. I don't think, and we produce loads of patient information leaflets. I mean, we've got them coming out of our ears, aren't we? And we all know online what our favourite sort of patient information leaflets are. But I don't think anything beats the face-to-face discussion about how you apply that particular piece of information to the particular child and family in front of you.
For people who haven't come across the Handy app, could you tell us a little bit more about that?
So I sound like I'm advertising. But you can download it from Google Play and normal App Store. You search Handy, Handi, stands for health and illness. And when you download it, it asks you what trust that you're working in, but actually anyone can download it from anywhere. When you open the app, it's then got 3 platforms. It's got a parental platform, a healthcare professional in the community, which is like GP, MIUs, and a hospital platform. And it gives you the guidelines for the big 6 conditions that result in admission to hospital. So if you're a parent, you can see what the guidelines are for medical treatment of your child with bronchiolitis. If you're a GP, you can see it. You can get all the patient information leaflets. So it's meant to be transparent. So across the whole system, you can see what the treatment protocols are, what the admission protocols are, what would happen when you come into hospital. So that we're all singing from the same hymn sheet, really.
Lovely. And do you have any other top tips for safety netting that you've not already mentioned?
So, one of the main things is about understanding the family and making it specific to their baby and understanding what they understand. There was some paper I read about the biggest difference that you can make with somebody engaging with you as safety netting is to sit down. It's a simple thing. But when you think about on ward rounds, we tend to be standing up, examining the patient, whatever. Sometimes in the postnatal wards, you might be standing up doing the first aid check and the mum's lying down. But apparently the thing that makes the biggest difference is sitting down so you're at the same eye level and having that conversation, which is probably just comes down to the communication.
Yeah, thank you very much. Next time,
we'll
be joined by Dr. Anna Baverstock. We'll be talking about some of her work in wellness, civility and inclusion. I was looking on her Twitter page and she seems to be an avid reader and frequently gives book recommendations on Twitter. I was just wondering if there were any books that you would recommend to our listeners or anything you've read recently.
Oh, what have I read recently? So, the last book I read, which I really like, it's nothing to do with, is it meant to be to do with medicine?
No, it doesn't have to do.
Is Lessons in Chemistry. It's a fictional book, but it's I think it's only in hardback at the minute, but it's about this absolutely inspirational woman and how she lives her life in a crazy, weird way. And she has a dog, so I know Flick and I both have dogs, and the dog almost takes part in the conversation and in narrating some of the book as well. It's great.
Oh, brilliant. It's Lessons in Chemistry.
Lessons in Chemistry. I can't think who it's by, but yeah.
No, that's all right. I will have a look. Thank you very much.
It's a pleasure.
Thank you for joining us today. Please let us know what you think of the episode.
That's all for this episode. As always, if you have any questions or comments, please feel free to get in touch via our email address podcast@pedshub.co.uk or via the PedsHub website. Equally, if you'd like to get involved, we always welcome your voices, so please do get in touch. Thanks for listening.